And there we go. Take it away.
Perfect. Thanks, Jason. Thanks for inviting me, and I'm happy to chat about this with your group. And I mean, I certainly don't mind being interrupted if people have questions, and I'm sure there'll be some time at the end for some questions or discussion. I have some limited interactive components, so which you can use your phone for. And there we go. Okay, I don't have any conflicts related to this. So the objectives for this talk were to provide an overview of antibiotic overuse and misuse, and specifically in primary care in Canada. Review the evidence for on antibiotic audit and feedback, and specifically in primary care. And I'll discuss some ongoing work that we're doing in this space as well for you. Okay, we'll see if this works. I'm trying Slido, which I think is kind of fun. So you can go to that link, or you can just scan the QR code on your phone. And I was going to get what people's sort of role or background is as part of the talk. I don't think I've met. I've met some people. I recognize names, but not everybody. So people can try that. We'll see if it works. It should be. Oh, there it goes. Getting some stuff in. All right, I obviously didn't think the choices through very well because I got a lot of others, but we can find out. We can talk about after what people's roles are, because I am curious. Um, so I think for this group, interested in antimicrobial resistance, this is probably not news, but this is an important and emerging public health threat. The WHO has described it as a slow tsunami that threatens to undo a century of medical progress. And it's much more than when we think of treating infections with antimicrobial resistance or complex infections in the community or hospital from drug-resistant infections is of course a big part of it, but it really threatens, several decades of progress, of medical progress that we've made in terms of being able to do solid organ transplants and more advanced chemotherapy and looking after, severely premature babies. All of these medical advancements are jeopardized by antimicrobial resistance because we won't be able to treat the most common complications of these procedures. So it really not only threatens our healthcare system, but really like a lot of our way of life. In terms of antimicrobial use or antibiotic use, comparing different countries. This is from the CARS report, what the Public Health Agency of Canada puts out every couple years. And it shows a couple things. One, that community antibiotic use makes up about 90% of antibiotics, and that's pretty true across the board. It varies bit by country, and Canada is about middle of the road. There's are several European countries with substantially lower antimicrobial usage than we use, and which overall probably should be similar for the degree of income and advancements of the countries. So whenever you see this much variability, it's usually a marker that there's room to decrease it in the countries that are overusing. And antibiotic use is associated with resistance. Again, I don't think this is news to anybody, and there are hundreds of studies that actually demonstrate this, both on an individual and ecological level. I've just put together a random group of European countries and their antibiotic use in the blue bars, and then one marker of resistance of an organism, so ESBL or ceftriaxone resistant Klebsiella species, and you can see that there's a strong correlation between the amount of antibiotics used overall in the countries and resistance for this organism that we're seeing. And it's true in multiple different settings. I wanted to share this study. Like I'm not going to go through it today, but if people haven't seen this and you're interested in antimicrobial resistance, this was a fantastic amount of work done by this organization's funded, I think, largely by the the Gates Foundation, but they tried to quantify the global burden of antimicrobial resistance, and it was a good effort. I think a lot of us used to quote the O'Neill report, which is a modeling study out of the UK, which has some serious flaws. Although this study is really quite good, with the obvious caveat of the limitations of data in a lot of places. But essentially, and this is very useful for communicating with stakeholders about why this is so important, but that there's about 5 million deaths associated with bacterial antimicrobial resistance a year, at least when this was done back in 2019. Um, and they also looked at the deaths attributable to AMR. So there's deaths associated with AMR, but then there's attributable deaths that they calculated as well, that basically would not have happened if it wasn't for the resistance part of the bacteria. And they estimate about 1.3 million deaths a year were attributable to antimicrobial resistance. Um, they also looked at by different regions and countries, and I think one of the interesting things is that you see like the lower income countries in Africa have much higher burdens of resistance. And this is mainly driven by the fact that the infection mortality is so much higher in these countries, and you can see Canada is there highlighted in that purple bar, combined with the U.S. Okay, I have another poll. So it should still be the same link on your phone, or you can scan the QR code and answer this question if you don't mind for me. So what proportion of antibiotic prescriptions in primary care are unnecessary? Yeah, so most people are picking 25 to 50%. And some people picked 15 to 25% or greater than 50%. And this drives, I think, a lot of at least what we're trying to do is that there's a lot of overuse in the community, and we should be doing more to try and correct that. Great. So this was a study that we did a few years ago now, looking at primary care practices in Ontario, and we used an electronic medical record database that has over 400 physicians and 500,000 patients as part of it, and it has billing claims, but also detailed clinical notes and records. And I mean, the way that we did this, the preemptive work we did for this was to classify diagnoses into these different groups that we work as tiers, and basically just the tier 2C and the tier 3 groups here are essentially conditions where really antibiotics should either never be used or rarely be used. Um, and when we did this study, what you can conclude is that there's about 25% of antibiotics that were prescribed in primary care that are unnecessary or likely unnecessary. And that's probably a conservative estimate, as you can see about half of all of the antibiotics we weren't able to adjudicate, either because there's no documentation whatsoever in the patient record, and we were pretty liberal about trying to attach patient records to those prescriptions, or it was basically a non-infectious code, things like anxiety or obesity or hypertension or something like that. So, and we felt we couldn't adjudicate that. We did not call those inappropriate. But you can see that it's probably an underestimate. But about 25%, I think, is a rough marker of what's going on in primary care. Another study that we did, and to inform the work that we were doing, is we uh, looked at, in the same cohort of physicians, we correlated unnecessary antibiotic prescriptions, which are on the y-axis, which we did in that previous study, with total antibiotic prescribing. And this is probably, I think this study sort of fell in the nice place between obvious and interesting, is that it's highly correlated. The more antibiotics you're prescribing, the more likely you are to be prescribing unnecessary antibiotics. And just to highlight another study, just as background, is we looked at the duration of antibiotic prescribing amongst all primary care physicians in Ontario. Um, and this graph, we just took out the 2,000 or so highest antibiotic prescribing docs, and on the y-axis are the respiratory antibiotics, or antibiotics typically used for respiratory infections, and on the x-axis the antibiotics are usually used for urinary infections, and just looked at the proportion of those physicians' antibiotics that are prolonged. The physicians with busier practices are larger dots. And we split it up by career stage, which when we did this study, the most significant predictor of prescribing more prolonged durations was the stage of career of the physicians, which obviously probably should not be guiding antibiotic prescribing. And you see this large group of outliers where the majority of their prescriptions are prolonged regardless of the type of antibiotic, were the later career physicians, which we defined as more than 25 years since medical school. And this matters. Like this was a nice meta-analysis led by Brad Langford and other people on our team at Public Health Ontario, where basically what we did is we took all the randomized controlled trials that looked at duration of therapy. I mean, usually these are powered for non-inferiority or the clinical outcomes or treatment failures, and we just looked at the drug side effects, so the adverse events, the antibiotic resistance, super infections from the randomized controlled trial, and basically what we determined is that for each additional day of antibiotics in these randomized trials, there was a 4% increased risk of adverse events. There was also non-significant association with resistance, which of course, none of these studies are really powered or set up to do or do the proper, there's no ecological evaluation or prolonged follow-up for that. But each day of antibiotic likely matters and contributes to harm to the patient. So I'll switch gears. I'm just going to talk about some of the work that we've done and are doing related to antimicrobial stewardship in primary care in Ontario, and specifically going to focus on the parts that I'm interested in doing research on, which is audit and feedback. So this is a study that we published in JAMA Internal Medicine recently. Basically looking at a single mailed letter to high antibiotic prescribers in Ontario. We using an administrative database, we took all of the high antibiotic prescribing primary care physicians, included them in the trial, and sent them this letter. And I'll walk you through what we did and what we found. So this was our letter that we designed for this trial, and I'll highlight a couple. I think things that I think are probably important for this sort of intervention, and there's some evidence for this. But one, that there's a central comparator and a central figure. I think it's important to keep the cognitive burden low, to sort of to maximize the impact and why they're getting this letter. Um, and so we did that with this simple figure that basically said they were getting it because they were the outliers in the in the 1 out of 4 physicians that were the highest prescribing in the province, and they're the 25% of primary care physicians who prescribe 65% of antibiotics in Ontario. The other thing is where it's coming from, and hopefully, the letter should be coming from somebody at least in an authority figure or respected. And we tried to partner with Choosing Wisely Canada, who's, I think, very well respected nationally. And we partnered with the section for General and Family Practice, which is the family physician wing of the Ontario Medical Association, and our group at Public Health Ontario. So all 3,000 docs that received the letter got these first 2 pages. There were 500 doctors that were as controls in this study. I'll show you which did not get a letter. And then we randomized the letter group into 2 equal groups. So 1,500 got this 3rd page, which was meant to target initiations of antibiotics. The idea was that we would give them these materials, which were modified from Choosing Wisely, to get them to initiate less antibiotic prescriptions unnecessarily for respiratory tract infections. The other group that was randomized to did not get that letter. They got only this 3rd page, which was on optimizing antibiotic prescribing durations. So recommendations for, evidence-based recommendations for common conditions about how long they need treatment for. And that was the intervention. So this is our flow diagram from the paper. So almost 13,000 primary care physicians are in Ontario. we just took the 3,500 roughly highest prescribing based on just volume of antibiotic prescriptions and enrolled them into the trial and randomized them into those three groups. We ended up excluding the top 1% of outliers from any analysis. For some data issues, there were just some implausibly high numbers at the extremes. And this is similar to what the trial in the UK did as well, where they had similar issues, and they actually excluded the 5%. So we excluded that 1% and then randomized the rest as intention to treat. This is our table one of the participants, just to highlight a couple things. The randomization was effective and successful. The groups were evenly split. Most of the doctors look like that gentleman on the right. So more years in practice, more likely to be male, much more likely to be from an urban center, and very high prescribing docs. So, median of 740 antibiotic prescriptions per year with a huge range, huge interquartile range. And then the split by the patient population is on the bottom, but about under 20% kids and just over 20% older adults. So these were the results in terms of the raw numbers. So just to highlight a couple things, so we had a few outcomes. So the main outcomes were the total number of prescriptions. The other one was the total number of prolonged duration prescriptions, which we defined as greater than 7 days. And based on that table and the evidence, most infections in primary care in the community can be treated with 7 days of antibiotics or less. So just to highlight, I mean, there were definitely downward secular trends at the time in Ontario. There's obviously seasonality to antibiotic use, but it overall was decreasing, and I think demonstrates the importance of why we actually did this as a randomized trial. Initially we went back and forth about just trying to do like a before-after study, feeling that this would this was the right thing to do and it was going to be effective. But based on all the evidence out there, we ended up randomizing both to a smaller control group. And I'll show you in a bit more detail, but you can see there's a small separation on the total antibiotic prescription lines between the control letter, which is the blue line, and then the intervention letters with the yellow and the gray. But if you look at the prolonged duration prescriptions, you can see more separation with the gray line, which is the duration letter, and I'll show you that. So here's just a graph of the results. And again, the raw numbers, and we analyzed it at 12 months after the single letter mail out. And so there was a small reduction from both the initiation letter and the duration letter, although the duration letter was the only one that was statistically significant, and about a 5% relative reduction in total antibiotic prescriptions. And then only the duration letter, we showed a significant reduction in prolonged duration prescriptions at 12 months, an 8% relative reduction. And these are the results from the study that show the different letters combinations. So the two letters, or the top line, we looked at the letters combined as a single intervention with three outcomes. As I mentioned, the total prescriptions, prolonged prescriptions. We also looked at antibiotic drug costs as another outcome. And just to highlight, the duration letter was significant for all three of those outcomes. So if all 3,500 high prescribing primary care docs in Ontario received this duration letter, we would have reduced antibiotic prescriptions by 147,000 over the year in Ontario. We would have reduced prolonged duration prescriptions by 84,000 and reduced total drug costs by $2.7 million. And that is just the cost of the drug. That doesn't include pharmacy dispensing fees or any sort of downstream costs related to inappropriate antibiotic use, which is substantial. So this is just the cost of the actual drugs. We did a number of stratified analysis in this study for both letters and for all the different outcomes. Just the only thing that was significant, which I think is worthy and interesting, is that for the docs that got the duration letter, on the outcome of prolonged duration prescribing. The only difference was that the docs that had been in practice for more years were significantly different from the younger docs who had been in practice for less than 10 years or less. And this correlates with the data that I showed you before, that was the population that really was not doing a good job, that they were prescribing for a lot of prolonged durations. And this had the biggest impact in that group where there clearly was probably an education knowledge gap in that area. So it was nice to see it having an impact there. I want to show you a few other examples of trials that have been done around the world in a similar sort of light of audit and feedback for antibiotics in primary care. So this is a nice study if people haven't seen from the US. So it's Jeff Linder's group. And what they did was they recruited 50 primary care practices in the US. And they randomized them to 3 different type of behavioral interventions. I'm just going to show you the audit and feedback arm, which was the most effective arm and also the one that had the only one that has sustained response. But they sent monthly emails to the docs randomized to the intervention that either told them that they were a top performer or that they were not a top performer. If they were in the top decile, they got the email that they were a top performer, and their outcome or their metric was antibiotic prescribing for viral respiratory infections. So most, 90% of the docs every month got an email saying that they were not a top performer, and to reduce unnecessary antibiotic prescribing for viral respiratory infections. And these were their results. So the 2 important things from it are the massive Hawthorne effect. So the blue circles are the control groups, control practices. So they were recruited into the trial, but then had no further communication or involvement in anything in the trial. And just by being told that their antibiotics were being monitored and they're in the trial, there was about a 20% reduction in unnecessary antibiotic prescribing. And I think that that's a powerful intervention in itself, especially for pretty poor performing practices at baseline. But the audit and the peer comparison, for feedback emails were very effective on top of that. And when they stopped the intervention at the end of this blue bar, it stopped going down, but it was sustained. It didn't go right back to the baseline. This is an example from the UK. So they did this in 2014, where they sent letters out to practices, not at the individual physician level, but the practice level, telling them that they are outliers. There are 80% of practices in their area prescribe less antibiotics, and it had a small but significant reduction in antibiotics. So they had a 3.3% reduction, which equates to 73,000 less antibiotic prescriptions in the UK a year. And they've continued with this intervention since. This is the example from Switzerland. So they did a audit and feedback trial in Switzerland. They recruited primary care physicians, and they sent them quarterly letters. So every 3 months, they got feedback on their antibiotic prescribing. Their feedback letter is here on the left. This was a negative trial, so it had no significant impact in antibiotic prescribing, which they measured in DDDs. And Jeff Linder and his group had written a nice commentary about why this is, and there are several reasons, but I think their feedback included too much data. It didn't really draw the reader's attention to the peer comparison component, and DDDs, I think, general physicians don't really know what to do with. And the risk you run by giving multiple different metrics of feedback about how you're doing is that physicians will tend to pick and choose what they feel they're good at or what they've sort of done well on in the intervention and ignore the parts that you maybe want them to look at. There's multiple interesting discussions around that can be had about why this didn't work, but this was a negative trial. Another example is from Australia. So this was a not published trial. It was posted on the government website, but it's overall a well done study. It's a pretty well done study, and what they did that's cool is that they randomized to basically 4 different interventions with a control group that got no letter, and they did an education only letter, which was not personalized. It just talked about the importance of antimicrobial resistance and gave guidelines on antibiotic prescribing. That had a very small impact, compared to the personalized letters with peer comparison components, which had much more impact. And the one I'm showing you here on the left had the most impact, which had that central figure to really catch their attention to the peer comparison component. Okay, so I was just going to spend a few minutes and talk about the trial that we're currently doing now, because we wanted to do something that was a lot more complicated. And it wasn't entirely, I mean, it was partially our fault. I think we wanted to try and answer interesting questions related to audit and feedback in general, and that was the real driver for the initial grant. But then things in Ontario got a bit complicated, and overall in a good way. So we used to have an organization called Health Quality Ontario, which was merged into like Ontario's new super agency right before the pandemic. It's called Ontario Health, but it still exists within that. And Ontario Health provides these My Practice reports to both long-term care and primary care. A few years ago, we added antibiotic indicators into the long-term care report. And then this year, we added antibiotic indicators into the primary care report, which I think was overall exciting, although it impacted our trial because we didn't want the same physicians to be getting multiple different types of feedback. And so, and with the challenges of budget cuts and the pandemic, Ontario Health wasn't really in a position to do any sort of trial concerning, modifying their reports and that kind of thing. So, but we ended up embedding two trials into this. So the Ontario Health reports got their antibiotic feedback report. And what we did is we mailed half of the doctors, randomized them and mailed them the viral prescription pad that was created by Choosing Wisely Canada. In our other trial, we call the PHO trial, is that essentially the My Practice reports are voluntary, and not all physicians are eligible, but most primary care ones are. But it is voluntary. You have to sign up and be interested in to get emails. Everyone who didn't sign up for those, we recruited them and we sent them letters through ICES. So we used antibiotic data. It's limited to patients that are 65 and older, but we any of the physicians that were not enrolled to the Ontario Health My Practice reports and who didn't opt out of our trial, we did give everybody an opportunity to opt out. We mailed them a letter to opt out. Were recruited into our trial. And we did a 2x2 factorial trial to study multiple different components of the letter, of the way that we gave feedback to try and improve things over time. And I'll show you what we did. So this was the Ontario Health part of the trial. If people are not familiar with this, this is the viral prescription pad developed by Choosing Wisely Canada. There are some good qualitative evidence for it. Physicians and patients both actually really like this prescription pad. To our knowledge, has never been studied in a randomized fashion. And so we are doing that. I mean, the physicians that get the emails do have access to it, but what we're studying is mailing an entire pad to the to certain physicians to see if it can further reduce antibiotic prescribing. And then in our part of the trial, essentially what we did is we had two factors in this factorial trial. There's the first factor, what we call adjusted metrics. And so this is the difference in the letter. Basically, we did a regression adjusted standardized antibiotic prescribing rate. So we took all of their patients' populations and we put it into a regression model, a hierarchical regression model, and then outputted their antibiotic prescribing rate adjusted for all their patient factors. And we tried to point that out at several points on the first page of the letter, that they're compared to physicians that are similar peers, that their rate is adjusted for their practice setting. Often what we hear with feedback is that my patients are different and this doesn't necessarily apply to me. And certainly in our first intervention, we heard that a lot, and it was partially true because we just sent them their total, it's just based on their total volume of antibiotic prescribing, not adjusted for patient volume or anything else. We do know, and I didn't show you those studies today, but we do know that this actually doesn't matter for antibiotic prescribing, that the patient case mix really doesn't drive inappropriate antibiotic prescribing. What we're testing here to see if telling the physicians that we did adjust for it, we did the work and adjusted for it, does that actually impact the outcomes we care about on whether or not they'll respond to the feedback? So that's what we're testing. The other factor that was randomized was a harms or no harms messaging. So everybody got this infographic about the lack of benefits for antibiotics in respiratory tract infections. But then we randomized to include this part of the graphic, which focused on the risk of harm. So side effects, resistance, death from resistance, and how unnecessary antibiotics can potentially harm the patients, to see if the more focus, there's some evidence that more harms messaging will increase attention to the feedback and prompt change. So we're testing that out. And this intervention has gone out. So the letters, it was delayed a whole year, and then it was delayed several more months, but we got it out early January. I'm not showing you the antibiotic use and COVID stuff, but obviously antibiotic prescribing and care has all been heavily impacted by COVID. But we sent out the letter in January, and then we also sent out the same letter in a follow-up about a month later to try and just increase people's attention to it. We know from our previous study that only about a third of physicians that received the letter had opened it. So just to summarize this part, so overuse of antibiotics leads to avoidable side effects and antimicrobial resistance, which I think everyone's probably very familiar with. A single mailed audit and feedback letter to the highest prescribing primary care physicians with education on appropriate durations resulted in a small but significant reductions in both total and prolonged duration antibiotic use. Prolonged durations decrease the most in older physicians who prescribe longer durations at baseline. And our current study will evaluate providing viral prescription pad, providing adjusted metrics, as well as harms messaging on antibiotic prescribing outcomes. Just the last thing I wanted to touch on was just to highlight some other stuff that we're doing. And so we assembled this international network through JPI AMR, which is the Joint Programming Initiative for Antimicrobial Resistance. It's a granting agency that funds network creation. And so right before the pandemic, we had submitted and actually got funding for this network to run for 2 years, which was delayed about a year because of the pandemic. But it's going now, and we've been moving forward for about a year now, and it's an international network and collaboration, and with the goal to develop best practices for the delivery of antibiotic prescribing feedback in primary care. And it involves, there's over 10 countries involved that are part of JPI AMR, as well as a few others. What we're doing, we're currently doing a systematic review and meta-analysis on antibiotic prescribing feedback in primary care. The network, we're in the process of developing a best practices resource and toolkit to try and help other areas and help the field in terms of implementing these interventions to the best that people can. The next step of this network is to identify gaps in future research priorities for, again, to keep advancing this field, and of course, knowledge translation is part of the network activities. And we're using modified Delphi methods and other things to try and put together these resources, which will eventually get published and disseminate. And this is the network, so it's over 30 experts, and these are, I mean, a lot of these people are real, serious, internationally renowned experts in the field, where people like Jeremy Grimshaw and others sort of help put these, get all these people together, and we got a little bit of money. And so, I mean, these networks, usually you're traveling and meeting in person, but we are so far doing it virtually. But I just wanted to highlight that this is happening, and we hope will help others interested in these sort of interventions in the future. So with that, I'll stop, and I'm happy to answer questions.
Thank you so much, Kevin.